So typically for our diabetic clients, we do have put a sign on the door or flag it someplace in their chart or on the actual door that they are on a carb count. We just want to make sure that everybody is doing the carb counting. If UAPs are taking out a tray, that we're getting what they've ate. We will do the carb counting, but we do need a slip of what they've ate to be able to calculate that properly, because most of our patients are getting a bolus amount of fast-acting insulin like Humalog or Novolog after they've eaten based on how many grams and or carb choices they have eaten. So super important that we don't miss the carb counting for our patients that are hospitalized. So even if they're not carb counting at home, they may wonder why we're doing it in the hospital. And we just need to explain that while they're hospitalized, there's an increased stress response. They might have an infection. They might be on medications such as prednisone that increase their sugar. There might be lots of factors of why we're watching their glucose a little bit more closely than what they may do it at home. One thing on this slide that I will highlight is the moderate serving sizes. Again, that's a big part of good dietary teaching for all patients. It's just that serving size, like we get so accustomed to just a way large portion compared to like other cultures too and other ethnicities and races and countries. So again, getting back to kind of just like a normal serving size can be a very good start on weight loss management, diabetes management, etc. Not skipping meals, making sure that we're at least having some healthy snacks. And again, number 4, pretty darn important too, avoiding or reducing those simple sugars and those real high, straight, sugar type food items. So I'm not making light or making fun of a someone with diabetes that has to really monitor their food, but I just thought this little cartoon was, pretty accurate, or could be pretty accurate. Always good to have some humor too. So this is the American Diabetes Association Evidence-Based Practice Nutrition Principles. So kind of just some general rules and things that we've already talked about as far as eating healthy. Again, the main goal is to avoid sharp, rapid increases in blood sugar after food. There's glycemic index in food items, which basically describes how much a given food will increase the blood sugar comparatively. So even choosing foods with lower glycemic index can be helpful as well. But we're going to talk through the carb counting, the grams versus carb choices, and there's a great active link here, a YouTube that's approximately 4 minutes that you can watch on more specifics on carb counting. I've added some nice pictures for you for those visual learners of kind of the healthy picks for diabetics and good fruits, bad fruits, etc. So we're definitely going to be getting into kind of what fruits and food items are 1 carb choice or 15 grams. But we do know, like for example, not that banana is a bad fruit because bananas are great, but bananas are high carb relative to other fruits. So for example, a banana would be equivalent to 2 carb choices or 30 grams versus a different fruit item, an apple, pear, whatever, that's just 1 carb choice. So, when we're having to choose, and it's not that you would never have a banana ever a day again in your life as a diabetic patient, but we have to kind of figure out if we're going to have 3 to 5 carb choices per meal, do I want to spend 2 carb choices just on a banana? That's where decisions are made by patients on what they want to choose. Because again, fruit is healthy, and vegetables are healthy, and there are lots of food items that are healthy, but we got to kind of figure out where it all fits into the overall plan. So we're going to get into counting carbs, and I just wanted to make sure when you're thinking of a carbs, it's sugar and starches. Anything that's a sugar or a starch as a carb. So you can see a lot of these food items that definitely would classify there. It's also important to know the difference between a complex carbohydrate and a simple carbohydrate. So you can see in the picture more of your simple carbohydrates they're going to have a higher glycemic index. They're going to raise the blood sugar quickly. So more of your sweets, the sugars, French fries, the breads, things like that, pop. So if somebody's hypoglycemic, we can give them 4 ounces of orange juice. That's a simple carbohydrate, a piece of candy or something like that, and that's going to raise the blood sugar. Complex carbohydrates are going to extend it more over time, so some of those complex carbohydrates might be a little healthier choices than the simple carbohydrate choices. And we'll talk also once for hypoglycemia management, what our protocol is for simple versus complex carbohydrates when we're actually treating somebody with hypoglycemia. We usually typically start with a simple carb, but once their blood sugar comes back up or is on the rise, we may also then give them a 1 carb choice of a complex carbohydrate to have more of a sustained improvement in their low blood sugar. So reading labels. So we're not going to start bombarding a new diabetic patient with reading labels, but it does become very important for them to start paying attention to counting carbs, initially just giving them food lists and items and approximation, and then kind of moving on to food labels. So we're going to do some practice on that. You're going to need to look at these and figure them out yourselves, read the labels. So we're going to go right to the total carbohydrates. You have to also pay attention to the serving size to get your correct carbohydrates, but this is showing 2% milk and Rice Krispies. So this is basically a bowl of Rice Krispies. But again, portion size super important. This is 1 cup of 2% milk and 1 1/4 cup of Rice Krispies. So if we're having a really big bowl of Rice Krispies, which I know I'm guilty of, it's going to be more than what we see here. But if we just have a very modest serving size, which this would be, we already have 12 grams of carb for the milk, which would be, we round that up to 1 carb choice, and then we have the 28.1 for if they had the full serving of 1 1/4 cup of the Rice Krispies, which will round up to 30 grams, which is 2 carb choices. So we have 3 carb choices just in a small bowl of cereal. So again, patients can choose, but there are some other meal plans for breakfasts that we can get a lot more food for less carb choices or the same carb choices. So really important to kind of work through some menus with patients and have them see the difference between items so they can start making their own choices. So here's a couple other common breakfast type items. So orange juice, so 4 ounces of orange juice is 17 grams, and we know that 4 ounces of orange juice is 1 carb choice. That's kind of our prime for treating hypoglycemia, is 1 carb choice, and which is going to be the fast-acting simple sugar like orange juice. And then on the right is an egg, and you can see with the egg there is less than 1 gram. So eggs are great. Those are going to be free items, no carb choice. So again, even if I have 2 eggs and 4 ounces of orange juice, which is not a bad breakfast, I've had only 1 carb choice. So comparatively to the 3 carb choices of a tiny little mini serving of Rice Krispies. So when we read the labels here, the chicken breast will come up as a 0 carb choice, only 1 gram. And you can see that beans, so this is, the beans are 20 grams. So this would be like your brown beans, your cans of baked beans. So those are a real starchy vegetable. So typically vegetables are free. Vegetables and proteins are typically free unless they are more of a starchy vegetable like beans, potatoes, etc. So that's where we have to sometimes differentiate, especially the few type of items in that vegetable category that would be higher in carb. So this is mashed potatoes. Again, I want you to look at the serving size, 1/3 to 1/2 cup. I don't know about you guys, but that's not a lot of mashed potatoes because we're so used to ginormous servings. But if we're doing that size, it's 1 carb choice. So again, you'll see on my general list coming up here, 1/3 to 1/2 cup of rice, pasta, potatoes, kind of any of those sorts of other things that we usually have with like a meal with vegetables and our meat and whatever are 1 carb choice. So we can kind of learn pretty quickly those that are going to be around that 15 grams. So here you see a fresh peach, 1 carb choice. Most regular, just a normal size apple, orange piece of fruit is going to be 1 carb choice, with the exception of a banana, which is going to be your 2 carb choices. So again, we can kind of standardize our fruits into one, with the exception of banana. And then this one you can see is the green bean. So this isn't brown beans, baked beans, this isn't the starchy bean, and we can see that that's 5 grams for total carbs, which if we're doing it by carb choices is going to be 0. If a person is actually counting by carbohydrate, by grams, then of course they're going to add the 5, they're going to add the 2, they're going to add exactly the number of grams. I just had to throw this in here. I love Coke. It's my downfall. I like to have 1 Coke every couple days at least, or 1 a day. But total carbs, look at there, guys, 39 grams. So, wow, almost basically 3 carb choices just from a can of regular pop. So, that's definitely just kind of a bad item for diabetic patients. Not that they can't enjoy some diet pop or other beverages that maybe are carbonated, because I think for me it's more of a carbonation thing. So again, we can maybe find some other choices that are satisfying for them. So these next several slides on menus are definitely fair game and things that you kind of need to know. You need to know how to look at a menu, what they've ate, figure out how many carb choices and what that total would be. The next step clinically would be, okay, how much insulin am I giving based on how much they've ate, based on their current blood sugar, and we'll have some practice problems like that as well. So if we look at this menu, the orange juice, half cup is 1 carb choice. The dry cereal, 3/4 cup is 1. The milk, a half a cup. So 8 ounces or 1 cup is 1 carb choice. So a half a cup of milk would be a half a carb choice. Eggs, 0. Toast, every piece of toast is 1 carb choice. So 2 slices of wheat toast would be 2. And then jelly or honey, and it doesn't really specify, but we'll assume that it's a regular and not a, unsweetened or whatever, or sugar-free. So 1 tablespoon would be 1 carb choice. So on this particular, then we have 5.5 carb choices. So we have 1 for the orange juice, 1 for the dry cereal, half for the milk, 0 for the egg, 2 for the toast, and then 1 for the jelly or honey. On this practice problem, we would have 0 for the chicken breast, 1 carb choice for the half a cup of mashed potatoes, 0 for the green beans, a half a cup of peaches, like the canned peaches, is 1. Remember, we said just a fresh fruit, 1 piece of fresh fruit would be the equivalent of 1 as well. Milk, 1 cup is 1. And then low-fat ice cream, a half a cup, is 1. So this particular meal is 4 carb choices. And again, I want to remind you, most of the time we want anywhere from 3 to 5. Obviously, it can be less than 3, but no more than 5 carb choices in one sitting. So here's 4 carb choices, and that's quite a bit of nice food, but it's portion controlled. That's the big thing. So I really want to emphasize the importance of this slide. Again, I've tried to help you out and do kind of a summary of common food items for carb counting. Clinically, we would have resources. We have on the menu specified how many grams for the serving size that's there right on the menu. We have things in our dietary room that have all of the different common items and how many grams or carb choices. But you want to kind of be able to really off the top of your head when you're working with your patients, talk to them about what's a carb and what's not. Here are some common, 1 carb, and because that's going to help keep it simple. So hopefully you will find that it's not as difficult as it may seem initially to kind of start to think about the different food items that are going to be equivalent to 1 carb choice, and then knowing that when you're in the hospital setting or nursing home, wherever you're working, that you would be able to use the menus and use the guides. But for our exams for NCLEX, I don't know, you're going to likely have to calculate without having all of those cheat sheets. So that's where you do need to do some initial studying and learning of these things. Sweeteners. There are two different types of sweeteners, nutritive and non-nutritive. So just the main thing is just to know that not everything that says it's sugar-free is sugar-free. So nutritive sweeteners you want to read the label. If they have fructose, sorbitol, xylitol, a lot of them have fructose, they are clearly not sugar-free. And so, yep, they're going to be better than table sugar, but they still should be used in moderation. Non-nutritive are the ones that you're probably most familiar with. Those are FDA approved for diabetes that will have minimal to no effect on a patient's blood glucose. So those are the NutraSweet, the Sunnet, the Splenda, minimal to no calories, and again, minimal to no effect on the patient's blood glucose. And then there are lots of different dietary natural products out there that have very low glycemic index that patients are getting really good about cooking with, baking with, or adding for flavor. So stevia and agave, those are all things that can be very beneficial. And again, for non-diabetic patients, we all should be a little more cognizant of this probably and make some small changes in how we cook and how we bake. And that can go a long way. The other thing is the Crystal Light to Go. They can add those sorts of things to like their water instead of pop or juice or other things that have high glycemic index, and maybe just kind of learn a new thing. Maybe they crave that just the same as they're craving pop. Educating our patients on effects of alcohol on blood sugar is very important. It kind of depends on a lot of factors, but just if in general, if alcohol is consumed on an empty stomach, it will inhibit the release of glucose from the liver, resulting in hypoglycemia. Of course, we know that excessive alcohol in general can lead to excessive weight gain or high cholesterol, high lipids. Also, we know that depending on what you're drinking, a lot of beverages, alcoholic beverages, are high in carbohydrates, or if mixing alcohol with colas or pops that are, of course, high in carbohydrates. So there's lots of factors with that. But the other thing is if a patient is intoxicated, they wouldn't necessarily be able to recognize signs and symptoms of hypo and hyperglycemia, which can also be dangerous, and especially with patients that are type 1 and on insulin pumps and maybe younger and not I don't want to say is experienced with knowing how their body responds to alcohol, but that certainly can be a problem. So we teach our patients to be very cautious with alcohol consumption. If they're taking insulin or taking any oral agents that are going to increase the production of insulin, such as a sulfonylurea. And again, if we're drinking, if they have a drink in moderation, so if they're having, statistically they say 2 alcoholic beverages for a man or 1 for a woman, that it typically shouldn't, necessarily affect their blood sugar. DKA may look a lot like alcohol intoxication, so we always want to be aware of that and make sure we're not overlooking DKA if somebody is potentially intoxicated plus in DKA. It's certainly a possibility. I found this nice educational handout, Drinking with Diabetes, and it just talks a lot. It has some very good points. It has like basically 10 things to think about. It talks about exercise and alcohol don't mix. It talks about, educating your drinking buddies. If we think of, younger population with type 1 diabetes, they want to be like their peers, and if they're at college or what have you, it's not as if they're not going to, potentially drink. So they really need to just be aware. They need to test their blood sugar more frequently and make sure that they are prepared and make sure that they're not going to go to sleep and then be hypoglycemic and not be able to wake up and recognize the signs. That's one of the biggest dangers, really. Overall benefits of exercise, I think you're very familiar with. We know that it significantly helps to decrease insulin resistance and help control blood glucose that way. It can decrease blood pressure, decrease cholesterol, help control weight or decrease weight, which will again help with the insulin resistance. Of course, it helps with stress and bone strength and heart health. So this isn't just about diabetes, but if we're thinking specifically diabetes, we're definitely helping with the insulin resistance for sure. There's some very important rules for exercise and diabetes. Normally, if the blood sugar is less than 250 and you exercise, blood sugar is going to go down. It's going to transport glucose into the cell to be used for energy. It's going to increase glucose uptake to the muscles and inhibit glucose release from the liver. So that first bullet is what normally will occur. So what we tell patients is that you should not exercise if your blood sugar is greater than 250 and or if you're testing positive for ketones if you're a type 1 diabetic. So the second bullet, if you're exercising when blood sugar is greater than 250, this is telling us that there's insufficient insulin to transport glucose into the cell. And so if we exercise, blood sugar, stress hormones are released, it's going to continue to go up. Blood sugar is going to continue to go up and still not have any insulin to transport glucose into the cell. Lack of insulin and lack of glucose taken into the cells will also stimulate that process of breaking down the glycogen for the energy source from the liver. So on top of not having insulin to transport the glucose into the cell, we also will have more liver releasing the stored glucose, so blood sugar goes up more again. And then the lack of insulin and glucose taken into the cells for energy will then also break down protein and fat for energy. So in patients with diabetic ketoacidosis type 1, that could put them into a full-fledged ketoacidosis. So the main takeaway is if your blood sugar is greater than 250 or if you have positive ketones, don't exercise. We also know that we don't want to exercise during peak action of insulin. We want to do more frequent checks before and after, and we want to make sure that we're taking snacks as needed. Again, here's a very good summary on exercise precautions. Besides the not exercising if blood sugar is greater than 250 and or less than 80, so we don't want to exercise when we're hypoglycemic either, this slide talks more about making sure that we have proper footwear, thinking about the chance of skin sores and breakdown, and perhaps if a patient has neuropathy, avoiding extreme heat or cold temperatures, making sure that you're inspecting your feet, making sure that we're not keeping on sweaty socks and sweaty shoes and things like that. Avoid exercise during periods of poor metabolic control. Well, that basically is the greater than 250 or the less than 80, or testing positive for ketones. Don't exercise during those peak actions of medications or peak actions of the insulin. Always want to check your blood sugar before, during, or after activity. Depending on the length and how intense the activity is will make a difference for that. Again, if the blood sugar exceeds 250, positive for ketones, do not exercise until blood sugar is stable. We recommend that patients that are exercising, and they will begin to really know their own body, but eat 15 grams or 1 carb choice snack prior to moderate exercise, and then check it afterwards, and usually will need a snack afterwards as well. If patients have an insulin pump, again, they are going to be very diligent about checking, but they may oftentimes maybe adjust their insulin pump and maybe turn it to half the normal basal dose during their period of exercise. And then lastly, it's really important not to exercise really later in the day or later in the evening when you're going to be going to bed, because you may go to bed and then become hypoglycemic when asleep and not recognize signs of hypoglycemia. This is another diagram that I found that I liked, and it says, lower than 100 on this. Some books say lower than 80, but either way, not safe to exercise if you're running low for your baseline. That may vary a little bit between that, 80 to 100 range. Eat a small snack, 15 grams or 1 carb choice before, and make sure that's up before you start. Has kind of that range, 100 to 250 where it's safe, and then of course greater than 250, we're not going to exercise at that time. On this slide, I just want to make sure that you never assume that because a patient has had diabetes or been diagnosed that they understand or that they're still understanding of all of their treatment plan. Everything is patient-centered and family-centered, and so we want our patients to best manage their own care, but we do need to talk openly with them about that. We have to ask them the right questions to identify what their needs might be. They can work with a diabetes educator. They can ask them if they're testing their glucose at home, what's going well, are they having any difficulties with anything. We have a whole bunch of things that we want to make sure that they understand. It's very complex, from the testing to the signs and symptoms of hypo and hyperglycemia to their medication schedule to how do they dispose their needles, and the list goes on. So we definitely need to be talking to our patients in the hospital, in their homes, wherever in the clinics, and even if they're not coming in with a diabetic related problem, if they're diabetic, we should be addressing what their needs might be. As far as monitoring, frequency in which patients are going to be monitoring is very individualized. Certainly if they have type 1 diabetes and are insulin dependent, it's typically going to be 4 times a day before meals and at bedtime, and or more frequently if they're having symptoms of hypo or hyperglycemia. Type 2 diabetic patients really, or pre-diabetes, really would depend on kind of how their management is, how their A1C is, what they're doing for medications. So some might do just once a day, a couple times a week, and then you'll have some patients with type 2 diabetes that are monitoring 4 times a day, just like somebody with type 1 diabetes. So it definitely does vary. One thing to note is that many times they will be monitored more closely in the hospital. Many reasons for that: during any infection, stress response, surgery, trauma, lots of the reasons that they're hospitalized will cause more release of sugars and cortisol in response to that stress. So their blood sugars may be more elevated, unrelated to their diabetes management, but because of other illnesses. So we tell our patients and reassure them about that. And then also they might be on medications that are specifically elevating their blood sugar, such as cortisone, the prednisone, steroids, especially. So again, we can reassure them that we are maybe checking that more frequently in the hospital because of X, Y, and Z, and then make sure that they know how often they're supposed to be checking it upon discharge. So we're always going to start with clean hands. At home, they'll use soap and water. We can use soap and water at the hospital too. We can use a little bit of an alcohol wipe or a skin prep, but we have to make sure that that is dry. Use the sides of the fingers, rotate, allow patients to decide if they're able to. That gives them a little bit of a autonomy in their blood draw, their capillary draw, that is. Capillary blood sugar, just to be aware of, can be 10 to 15% less than serum blood sugar or a lab draw. So if we get a capillary blood sugar, for example, that is 40, we know that that's significant. So making sure that you understand how it may look, capillary versus serum. The other thing to ask patients about is if they have had their machines calibrated. So if they do have their own monitor at home, have they recommend like every 6 to 12 months. It may depend a little bit on the machine, but some patients have had a machine for a long time and haven't ever done anything with it. So a good time to just kind of ask them about some of those things while we have them in the hospital. There are new testing such as continuous blood glucose monitoring, and that's monitoring glucose levels in the interstitial fluid to provide more of a real-time glucose info to the user, like every 1 to 5 minutes. So many sensors require a couple cap readings per day for calibration, and there will be a lag time between the capillary glucose and the glucose sensor value. So again, make sure that we understand if they do have a continuous monitor, what that may mean to us. This slide is pretty self-explanatory. It's just talking about some times where a finger stick, a capillary blood glucose check would not be warranted. Also a good time to remind you of times where it may not be appropriate to delegate blood glucose to a UAP. I thought this was cute for a little bit of humor, maybe not cute or humorous to somebody who's diabetic and has to do capillary checks, but just like to add a little bit of humor to the PowerPoints as well.